Recording in progress.
Welcome to today's session. Today we have an exciting presentation. We will be looking at pediatric treatment failure, pediatric HIV treatment failure, and just some principles around it. And I do hope you will be able to appreciate the session and you'll be able to use it in your practices. But what I'm actually looking forward to is to hear some of your experiences that you're having in your facilities. Would like to hear you share those experiences, what are the struggles, and just how you are getting around with managing children who are failing treatment. And so we would like to enrich this discussion, so we want to hear from you. We'll be looking forward to hear from you. Thanks. So I just want to thank the teams that are joining in, the subject matter specialists. I know we have Dr. Kevin Zimba on the call. We have, I can't see who else we have here. So we've seen Dr. Thomas is on the call. Thank you, Dr. Thomas, for joining us. And we have also Dr. Francis Mpeta is on the call. Thank you for joining us. Yeah. And then also we have the network that has joined us from different places. I see ZAF Logistics Command is on call. Thank you for joining us. And then we have a few others from different places in the country. Thank you for joining us. So Dr. Maria also, thank you for joining us. Here we have at the hub, I'm joined by Dr. Manzi, who introduced herself, has done a lot of work in pediatrics, and she's here just to share experiences of how she's managed pediatric patients at Matero and in Lusaka province as a whole. So we're happy to have her with her today. So without further ado, I will just share the slides and ask Dr. Manzi to just introduce herself to the network, and then we'll get on with the presentation. I hope you can see the slides. Anybody just to confirm that they can see the slides? Okay, thanks. Thank you so much. Seems like it's still loading. Well, we're good to go. Thanks a lot. So I'll just hand over to Dr. Manzi just to introduce herself as we get down into the presentation.
Thank you so much, Dr. Ziambo, and good afternoon, dear network. My name is Victoria Manzi. I'm a TB HIV medical officer from Lusaka Provincial Health Office. And like Dr. Ziambo said, I've worked at Matero General Hospital and Pediatric Center of Excellence for 2 years. And I've also been a mentor in pediatric HIV countrywide. So through these 2 years, I've had experience to manage some of the pediatric clients, both those who are doing well and those who are failing. And together we'll be able to share some of the experiences and the best practices. Thank you. You can go to the next slide. Okay, so the learning objectives, mainly we have 3. We'll highlight the roadmap to treatment failure in the pediatric patient. We'll discuss the approach to pediatrics who are failing treatment, and we'll showcase approach to various cases of treatment failure in pediatrics. So great strides have been made in the field of pediatric HIV over the last 15 years. improvements in antiretroviral treatment have enabled many children to reach adulthood and achieve their goals. However, many problems with pediatric HIV treatment remain and often place children and adolescents at risk of failing their treatment. These problems include limited available fixed dose combinations of ARVs for children, poor palatability of the existing ARVs for pediatrics, dosing complications with pediatric ARVs, the many psychosocial and social issues around the administration of chronic long life medication and maintaining long-term adherence. So due to all these problems, it's not surprising that the treatment failure rate in children and adolescents with HIV is much higher than in adults.
Okay, thank you so much. So we have our first poll. We just want to interact with you further. So we would like you to just participate and see which one is correct. So in this poll, we're going to read together. We have Dumisani, who is a 2-year-old and has been on ART for 7 months. The viral load test at 6 months post-initiation of treatment is 8,000. With reference to this case, answer true or false. For children, viral load may still be detectable at 6 to 9 months after initiation of ART and does not necessarily mean treatment failure. Is this a true statement or false? So for viral load, for children, viral load may still be detectable at 6 to 9 months after initiation of ART and does not necessarily mean treatment failure. Is this a true statement or not? So do we think Dumisani, 2-year-old here, who's been on ART for 7 months, and the viral load at 6 months says 8,000. Do you think that this is treatment failure or not? I appreciate everybody who's participating. And so far we have about 56% participation from those that are connected. Okay, so we have a few more seconds before we close the poll. Okay, we'll close the poll. Dr. Manzi, see, we have this distribution. Most people think it's true, about 64%. The rest think this is false.
Okay, thank you very much. I think we'll discuss as we go on, and we'll learn what that result means. So we'll now look at ART treatment failure, and we'll define it. So ART treatment failure is defined by a persistently detectable viral load more than 1,000 copies per ml. So for adolescents and adults, failure is 2 consecutive viral load measurements within a 3-month interval with adherence support between measurements after at least 6 months of using triple combination ARV drugs. For children, viral load may still be detectable at 6 to 9 months after initiation and does not necessarily mean treatment failure. So this is because children take much longer to reduce the viral burden that they have compared to adults. So if a child has been on treatment for 6 months and you do the viral load, it's above 1,000 copies, it may not necessarily mean that they have ART treatment failure. So viral load is recommended as a preferred monitoring approach to diagnose and confirm treatment failure among people living with HIV. So we know that routine viral load monitoring should be carried out at 6 months after ART initiation, at 12 months, and then every 12 months thereafter if the person is established on ART, to synchronize with routine monitoring and evaluation reporting. So in circumstances where viral load testing is not available, which is very rare in our setting, the CD4 count and clinical monitoring should be considered as an alternative to diagnose treatment failure. So adherence counseling should be provided at all visits to ensure that viral suppression is maintained or given priority throughout the treatment. So let's look at the causes of ART treatment failure. So there are a number of things that can cause ART treatment failure. Firstly, poor adherence. So poor adherence has been studied worldwide and has been established as the commonest cause of treatment failure. Adherence barriers must be explored and corrected before the therapy is changed. And later in the discussion, we'll go into discussing about poor adherence and the causes. Suboptimal doses. This is very common in pediatrics and in practice. Some of us who are working, we've had cases where a child is given suboptimal doses because the scale was not available or the weight was not recorded because of too many body collections. We keep giving the child the dosage that they were eligible for 2 years ago, and we haven't seen the child at the facility. So that may lead to ART treatment failure, or where a child acquires an already resistant virus from the mother. So it's important to also look at what ART is working for the mother. Then prior exposure to some ARV drugs may predispose someone to end up with ART treatment failure. And here we point out a case of NVP monotherapy that was used in the past for PMTCT. So let's look at causes of poor adherence, as we have seen that it's the main cause of treatment failure. So there are numerous causes for poor adherence, including both patient-related and health system-related reasons. So patient-related here, we are talking about reasons. So these are barriers based on psychosocial situation of the patient. So they have to do with the patient. Health system-related barriers to adherence are based on the problems within the health system that affects the patient's ability to remain adherent to treatment. So this is a table that is showing those causes of poor adherence according to these categories or a classification, which I found very useful and I thought of sharing. So patient or caregiver related factors. As we know, in pediatrics, the children rely much more on the caregiver. So number one, it has to do with logistics. Should the child miss school to go to the clinic, or should the caregiver miss work to go to the clinic? Sometimes maybe they travel out of the area where medication is collected. Issue around stigma. There's still a lot of stigma around HIV. It can be self-stigma or stigma from others. Issues with disclosure. So we've had a lot of issues with caregiver, maybe a mother who's in a new marriage and has not disclosed the HIV status to the partner and cannot freely give the drugs to the child or take her own drugs. So those issues can lead to poor adherence. Lack of social support system or a treatment supporter. Mental health issues. So we have caregivers who have mental health issues, and those need to be addressed. Substance abuse is another challenge. So if a caregiver abuses maybe alcohol or other substances, they will be drunk and they will not give the drugs to the child at the time they are supposed to. Violence and safety concerns or an unstable home environment. So we have had cases. I think the most recent we had was a case in Chilanga where the parents are divorced. One is living in Chilanga, the other one is in Kafue, and the child moves from one home to the other, and there are issues around stability. So this child doesn't take the medication depending on which caregiver they are with. So you can have an unwell or disintegrated caregiver. The caregiver can become fatigued of giving treatment. Remember, this is a chronic illness. Someone has to take the drugs lifelong, but people can get tired. Competing priorities, food insecurity, and an unstable home life. So those are patient or caregiver-related factors. When we look at regimen-related factors, here we are looking at chronicity of medication, side effects of some of the drugs, pill burden. Okay, remember in pediatrics, there are limited fixed dose combinations. The mother has to get from one bottle, get from another bottle, and there are so many drugs that they have to give that can really affect the adherence. Complicated dosing regimen. So we had a case where a grandmother was giving ABC3TC and DTG. So when she came to the facility, we noted that the child's viral load was still high despite being on that optimal regimen. So we asked her to explain how she was giving the medication. And what she told us is, in the first month, she would just give from the DTG bottle. In the second month, she was giving from the ABC3TC, and she still had a lot of medication. So when she was called to come to the facility for the appointment, she said she already had drugs. But from the pill count, we thought the drug should have run out at the time. So those complicated dosing regimens needs to be simplified so that the caregiver is able to administer, especially elderly caregivers. Poor palatability of medication, we all know how beta lopinavir is, but we are glad that now we have DTG, which is more palatable. Health system related, so these have to do with the health system. Poor access to facilities, inefficient services and long waiting times. So we need to improve on sticking to appointment times so that they don't spend so much time. And we also marry their appointments for the caregiver and for the child. Poor HIV education. So sometimes we've taken it for granted that when someone is diagnosed with HIV, they know everything about HIV. Education is continuous because adherence can change at a different time. Someone who could have been adherent a year ago, they could have met a man of God who told them that they're now HIV negative. So patient education is very, very important. We could have medication stock out, negative staff attitude, and requirement for multiple visits. So this is just a picture showing how pill burden can be a challenge. Look at all those tablets and someone has to swallow them. That can affect adherence.
Thank you very much. I was just wondering, Dr. Manzi, how you picked on a man of God. There are women of God as well.
Not very common.
The following are types of ART treatment failure, except, so I'll just launch that poll question. Okay, so the following are types of ART treatment failure: immunological, clinical, increase in CD4 count, virological. Very interesting session so far. Following are types of ART treatment failure, except. So you would pick what you think is not. Okay, so I'll end the poll. Most people think the correct answer is C. Okay.
Yeah, so Moving on, we'll talk about the types of ART treatment failure. There are 3 types. Virological, this is where the virus replicates and increases in number. Immunological, thereby follows where the immune system is overwhelmed by the virus that has increased and the CD4 cells reduce. Then we have clinical. This is when opportunistic infections begin to manifest and is a sign of advanced HIV disease. So virological failure, this is where you have viral load above 1,000 copies per mil based on 2 consecutive viral load measurements 3 months apart with adherence support following the first viral load test. Immunological, so for children younger than 5 years, so there are 2 schools of thought or 2 definitions that I came across where others will use the CD4, the absolute CD4, because there could be machines that are not able to maybe print out those percentages. So the guidance from WHO is that you can use a threshold of 200 cells for those less than 5. But if you are able to get the percentages for less than 2 years, we consider less than 15%. Then for those between 2 to 5, less than 25% of the CD4. Then for older than 5-year-olds, persistent CD4 count below 100 cells. Clinical failure, this is where you have new or recurrent clinical event indicating advanced or severe immunodeficiency. So here we're talking about WHO staging 3 or 4 conditions with the exclusion of TB after 6 months of effective treatment.
The next poll. So in this poll, we're asking, several studies have shown that 30 to 60% of treatment failures are as a result of poor adherence, and clients are able to attain viral load suppression after undergoing EAC with a trained healthcare provider. This statement, is it true or false? Go ahead and poll. So, do you think this statement is true? That about 30 to 60% of those that are found to have treatment failure, it's as a result of poor adherence. And usually when they're given EAC, they will be able to suppress. Okay, we've got good participation on this. About 60% so far managed to participate. So we are only remaining with a few seconds. Okay, I'll end the poll and share the results. So most people think it's true. A few, about 4% think it's false. Okay.
So thank you very much. And now we'll look at approach to care for children with treatment failure. So we all know, and we've seen in the slides before, that poor adherence to ART is a most common reason for unsuppressed viral load, both in children and in adults. And several studies have shown that about 30 to 60% of treatment failures are as a result of poor adherence, and clients are able to attain viral load suppression after undergoing EAC with a trained healthcare worker. And because of that, WHO has recommended EAC to address this problem. So other studies have also shown that EAC leads to viral suppression in over 70% of patients with viral load suppression. So what is it that we need to do? We need to explore and correct the barriers to adherence through EAC before the therapy is changed. So what is it that we have to do when we have a child who's failing treatment? We need to conduct a comprehensive evaluation of the opportunistic infections, such as TB, and we treat according to national guidelines. Genotyping studies to confirm resistance has to be done. And when we have ascertained that there is treatment failure, the failing regimen should be changed to more efficacious regimen. We need to optimize the dosage and the regimen in pediatric clients. And here we always need to remember to use the weight to make the dosage.
Okay, and another poll question. I hope you've been able to follow as we go through the rest of the didactic and the answers to the poll questions. So this one here, we have John, a 7-year-old who has been on ART for 4 years. He has been noted to have high viral load in the past 2 years. He is currently on ABC3-T-Sildenafil. His genotyping results are still pending. His latest viral load is 297,554 copies per mil after extended EAC. He lives with his mother, who is also on ART and is suppressed. How should the clinician manage John? These are the scenarios that we're meeting every day on the ground.
Yeah.
I would like to see how the network responds to this one. I'm so much looking forward to this. So dear network, please go ahead and make a decision for us here. We have John, 7-year-old, on ART for 4 years, but has a viral load, which has been high for the past 2 years. And after EAC, the viral copies still are in the 297,000, very high. And his mother was on ART and the mother is actually suppressed. How do you think we should manage John? Very practical question. Do we switch him to second line? Do we evaluate John for any opportunistic infections accordingly and manage accordingly, or consider enrolling him in DOTS or all of the above? Very interesting answers so far. Only 42% have had the courage to give us an answer. Please give it a go. What are you going to do? What do we do in our facilities when we have such a scenario? I can even point at some of the facilities where we've seen such scenarios. We see all the time. I know you Lusaka guys, we have got some really good facilities where Dr. Mans is coming from, Matero, George, we have quite patients like this. Chawama. Okay, thank you so much. We have about 61 participation, and most of the people think it is all of the above. Most people think it's all of the above. A few think you switch second line. Another few think that you evaluate for opportunistic infections. Yeah, so end here the poll, and we'll continue with the session.
Okay, thank you very much. So John is actually a real patient, one of the patients that I took care of at the facility where I was working. And yeah, what we did for John is all of the above. We screened for opportunistic infections. We enrolled the mother in DOTS. And what we did is we tried to borrow the DOTS approach from the TB program, and we've tried to use it where we can identify someone from the home, a caregiver from the home. So we use the grandfather to do DOTS on both the mother and the child. So to check that the medication is being given, and we switched him to second line. Yeah, so I'm glad to announce that John is now suppressed. Yeah, so.
Fantastic.
Yeah, so before switching therapy in suspected treatment failure, healthcare workers need to rule out poor adherence. So you only change the therapy after EAC has been conducted and the barriers have been addressed. If the barriers that you identified are still there, then you are going to extend the EAC. You are not going to switch, but you are going to extend the EAC. So you can have a client we had an adolescent who was coming to get the drugs, and he was throwing away the drugs. So his viral load was just in the skies, and we really didn't understand. This is someone on an optimal regimen, but the viral load is just in the skies.
Okay.
So then send for genotyping, and the genotyping comes, is susceptible to all the drugs.
Yes, yes.
So
yes.
after now engaging the client now opens up and says, actually, I do not take those drugs. So the drugs only work if someone is taking them. So you need to address the barriers before you can think of switching to second line. Second line is actually more complicated than first line. So you need to think of IRIS. Remember, this is a client who's been studied on treatment. Within that 6 months, they can end up with IRIS. So treat underlying conditions and continue ART if tolerated. Untreated OIs, you need to treat them and continue ART. Think of pharmacokinetics. Some of the clients, when we diagnose them, we're also starting TP treatment. Sometimes it can be an oversight, even from a clinical point of view, where you forget to double dose the regimen, and the person at the pharmacy doesn't double dose the DTG. So you're giving an underdose because the rifampicin in your ATT is going to wash off your DTG or your lopinavir and reduce the concentrations. Treat any current infections that could reduce a CD4 count, and then repeat the CD4 count after a month. Can we go to the next one? So finally, I would like to share some change ideas in the management of treatment failure in pediatrics. So these are some change ideas that we've come up with as we do mentorship in our different facilities in Lusaka province, and these have been shared with the clinicians. So one thing that you have to do is ensure that the child is on an optimal regimen according to the national guidelines, preferably a DTG or lopinavir-based regimen. Simplify the regimen. So here, ABC3TC, when it was being given with lopinavir, mostly we were giving ABC3TC twice daily. But when we are giving with DTG, you need to combine that dosage and make it as a single combination, like ABC3TC combined as a once daily with DTG for those on first line. Then weigh the child at every visit. I cannot overemphasize this because we know that this is crucial in deciding the dosage in children. Update the dosage in the child's care card and the file according to the changes in the weight. So every time the child has moved from one weight band to the other, this has to be updated. Avoid too many body collections. This has been a very big issue where the caregiver will come to the facility and you just dispense. So a year you have not seen the child, you're just dispensing. And the guidance that we are currently using is there should not be more than 2 consecutive body collections in a year, because most children will grow rapidly and the dosage may need to be adjusted regularly. So the other thing is you need to screen and treat any opportunistic infections. Then always ask the caregiver to bring the bottles of the medicine to assess and reinforce adherence. This is something that we've seen, and from the story I shared of the grandmother who was giving DTG at one time in a month, the next month she's giving ABC3TC. You can only know what the caregiver is giving and how they're giving it if you ask them to bring the bottles to the facility. We had another caregiver who says, DTG causes abdominal pain when I give to my child. So she was only giving ABC3TC. So it's always important to ask the caregiver to come with the bottles and ask them to explain how they are giving, such that if you're increasing or changing the regimen, you tell them to say, since you are giving 1.5, today we are changing, you'll be giving 2 tablets. Yeah. Do not hesitate to switch to second line for those that have undergone EAC and caregivers proved adherence. Do not hesitate. Always consider genotype tests in all the clients with high viral load. Just when you get high viral load, send for genotyping. Enroll the child in a DOTS program. It can be a treatment supporter who goes to take the ART. It can be someone in the household, maybe the mother or a grandfather or an aunt who knows about the child's status, who can provide dots. Dots can also be done at the facility. We had an adolescent mother with twins at Ngombe Clinic who was going to get the drugs for the babies from the facility because she could not administer the drugs and the viral load were just high for the babies. So every morning she would go and get the drugs and administer in the presence of the nurse at the facility. So caregiver support, very, very important. Remember, caregivers also need psychosocial support. They need to meet with others and discuss with those that are going through the same. Finally, do not hesitate to consult when you're in doubt. There's 7040 you can call and consult.
Thank you.
So in summary, for children, viral load may still be detectable at 6 to 9 months after initiation and does not necessarily mean treatment failure. Poor adherence to ART is the most common reason for unsuppressed viral load. Causes for poor adherence include patient-related and health system-related. Before switching therapy in suspected treatment failure, the healthcare worker needs to rule out, firstly, poor adherence, immune reconstitution, inflammatory syndrome, untreated OIs, pharmacokinetics with other drugs, and current infections that can cause a transient decrease in the CD4 count.
Thank you very much. Thank you so much, Dr. Manzi. So we have an opportunity to just redo the poll quickly before we invite comments and questions. And I'll go to the, okay. So this one, dear network, you can poll. For children, which one is true and or false here? For children, viral load may still be detectable at 6 to 9 months after initiation of ART and does not necessarily mean treatment failure. Is this true or false statement? Oh yeah, it's, the answer is right there, it's true. Maybe an explanation? I think it's something that you've already emphasized in our session, maybe just to reinforce, because I've seen some people still picking false.
Yeah. So I think all of them are, the answers are already highlighted, so I don't know whether you want to respond.
No, just emphasize.
Yeah, the response to this one, it's true because children, unlike adults, take a bit more time to reduce the viral burden from time of infection. When you look at what happens when someone is infected with the viruses, that increase and then is that drop. So when someone is initiated on treatment, the way they are going to respond in a child and in an adult, there's a difference. So it may take a bit of time for them to reduce that viral burden, and studies have shown that. So you may have to think of what else could be going on. Mm-hmm. Are there opportunistic infections that were not treated before you can conclude that it's actually ART treatment failure?
All right, thank you so much. That's why that is true. So the next poll question is the following types of ART treatment failure except. I think this is obvious. C is the answer here. It shows increase instead of decrease. So move on to the next question. Question 3. This one was interesting. Several studies have shown that about 30 to 60% of treatment failures are as a result of poor adherence, and clients are able to attain viral suppression after undergoing ART. True or false? So this is a true statement. So maybe you could run us through why it is true.
Okay, so from different studies that have been done, adherence has been identified as the most common cause of ART treatment failure. And if a client undergoes EAC, most of them will achieve viral load suppression. So the most important thing is to deal with the poor adherence.
The barriers.
The barriers.
The barriers.
So the barriers identified should be dealt with. Once you've identified the barriers and you've dealt with them, most of the clients will actually attain viral suppression. And a lot of studies have actually been done in that regard.
Thank you so much. The final one. This is your experience you had. I think you did discuss this one. So I think, I don't know if there's any other emphasis you want to make on this one.
Yeah, so there are so many Johns out there, so many facilities we visited that are still struggling to manage children with high viral load. Some of them have had, they've never felt what it means to be suppressed. Like from the time they started treatment, the viral load is just always unsuppressed. And we should not look at it at one, like as one problem. Sometimes as clinicians, it's always encouraged that you get engaged in the EAC sessions, because there's some things that you may get that a treatment supporter may not get, because we are leaving the EAC to the treatment supporters. But when you get involved, you find out other things. So when you're ticking on the barriers, when you look at the EAC form, you don't have to tick only one barrier. So the only thing maybe they'll tick is forgot to take the medication. Look at other barriers. Who is at home? What is the setup? What does a mother do? This is a marketeer who goes in the morning at 4 o'clock and comes back at 20. So who's administering the drugs? A young girl who's given instructions. So sometimes they'll follow the instructions, sometimes they will not do it. So you need to explore those barriers before you can. Yeah.
So this is actually very common, because I think I was seeing another patient last week who has an opportunity to have all the drug resistance. The drug resistance was done and was acceptable. All the ARVs are acceptable, but he says he's drinking medicine. His father says he's drinking, and then but he's the 200,000 in terms of viral load. So, and as usual, the people involved in the EAC were not really clinicians. This time around, we took the boy to be seen by somebody, by a nurse, by one of them. And they actually managed to find out that the boy actually doesn't even actually take the drugs. And that's because of a family situation where he's staying. His mother died a long time ago, and the one he's staying with is a stepfather, and things like that. So there are all these social issues that are always surrounding these children, and they'll need a lot more support.
Yeah.
Okay, thank you so much. We will stop there for the slides and get to the comments. I know I've seen quite a number of comments. So, and there's a hand by Simwanza. Please, Simwanza, go ahead and unmute yourself, and you can ask your question.
Thank you very much, Dr. Kozia. My question is with regards to the data and the studies which are showing that pediatrics take a little bit of time to actually suppress, 6 to 9 months. It's in line with that. So looking at that data, and we know that data actually informs the decisions or what we are putting in our guidelines. So when will be the most appropriate time to do a viral load monitoring for the pediatrics who've just started treatment? That's the first question. And when we look at a pediatric who has got a higher viral load at, let's say, 6 months, and back in our minds, we are considering that they may take a little bit of time to actually suppress, should we engage or should we enroll the client in EAC? And if so, when would it be appropriate for us to engage and enroll the client in EAC? Looking at that situation where they take a little bit of time to suppress. Thank you.
All right, thank you so much. Very important questions. I don't know if you caught the questions. You can respond to them.
Okay, so thank you very much, Mr. Simwanza, for your questions. So looking at the fact that pediatric clients will take a bit of time, so the range is from 6 to 9 months. Really, the guidelines that are there is that when you do the viral load at 6 months and the viral load is high, you don't have to rush to switch to second line, but you can, like you enroll them in EAC and repeat the viral load at 9 months. So that will be like 3 months after that, because we know by somewhere around that time, they should have achieved the viral suppression. That is why now we are encouraging that at the time of initiation, the client is enrolled in DOTS just from the beginning, so that someone is observing how the medication is being given. We shouldn't wait for a client to fail treatment, then we start thinking about DOTS. So maybe for uniformity's sake, the guidelines have been left that we do it at 9 months to avoid confusion. But what we do is you enroll in EAC. EAC is just like enhanced adherence. Adherence is done at every visit. But in EAC, you are looking at, could there be any barriers that are there? And remember, now we also do the baseline viral load in the guidelines. So if you have a baseline viral load, it will also guide you and you'll be able to appreciate where you're coming from. By the time you do a viral load at 6 months, you appreciate whether there is a decline, and knowing, let's say this child started at 5 million, and then 6 months later, they are at 900,000. You know that there is an improvement, and you don't necessarily have to start panicking, switching to second line.
Thank you so much. Any comments from the experts on the call on that? Dr. Chipasha?
Yes, good afternoon, Doc. Thank you, Dr. Maz. That was a very good presentation and very clear. Just to add to Dr. Maz's feedback, I think the clinician would also do well to look at the log drop in such a client, the pediatric client who, in as much as we're being told the viral load is not unusual to find it still high after 6 to 9 months on ART. So we know that if the child is on efficacious drugs, then we're expecting the log drop to be not less than 2 logs. Okay, that would demonstrate that at least something is happening. But as Dr. Mazi was explaining, if the initial baseline VO was, say, 1 million or 2 million, and then you're still in the millions when you repeat the viral load after six months on ART, then clearly there's something that is not happening with regards to the child taking the drugs as instructed. And so it would be wise for us to still enroll every child who's going to have a high viral load at 6 months in EAC, and DOTS to commence just as we are receiving the results. I think that's been something we've been emphasizing with our facilities. So we shouldn't wait for a repeat viral load to now talk about attaching that child to a buddy who will watch them swallow the tablets, but they need to start that as soon as the results come in. And the issue of the children also coming with the bottles to the facility, I think we're still lagging a bit behind there, because we're still seeing caregivers coming to the facility with the children without the bottles, or they keep changing caregivers. And so it would be very difficult to have the caregiver demonstrate what exactly they are doing for the child when they're home. So we'll do well to work very hand in hand with the providers and the caregivers to make them understand what would like these caregivers who are with the child at home to be the ones to be coming with the child at the facility, so that the adherence is thoroughly done. Thank you.
Thank you so much. There was a question here. I don't know how long are we supposed to give dots for?
So directly observed therapy, it depends what it's being used for, because like I said, we are now using dots even for those who are newly initiated on treatment, just to ensure that the caregiver is giving the medication. So they may go up to 6 months or a year, then their window of the dots. Then for those who are failing ART, remember we are doing EAC for 90 days. So we do directly observed therapy through the EAC process, and then we repeat the viral load. Yeah, so once they are suppressed, then they can graduate from dots.
Yeah, I see. It makes sense to have direct observed therapy during EAC, because that way you will know that there were no issues with taking drugs, because that's what leads to what we are seeing, that so many children are actually having undergoing EAC for 1 year. People continue to provide EAC for a whole year. I've seen a comment here that we need to emphasize that there are some where you're giving EAC for a whole year, you're just doing EAC and you're not deciding to start on secondary treatment. And so probably that's one of the reasons that you're not too sure whether they're taking or not. And so I think emphasis needs to be made that once we find someone with a high viral load, we do the EAC, we are sure that they've been taking drugs and they're just failing, we move on to the next, and that is give a second line. And yeah, thank you so much. Any other comments from the experts? Dr. Thomas, would you like to make a comment about this discussion?
Thomas can comment on the retaining of the viral load result.
Hi, good afternoon, everyone. I think nothing from me. Thank you for the good presentation. Thank you.
Thank you so much, Dr. Thomas. I don't know if you would also make a comment on the turnaround time for the drug resistance testing. But I know
Dr. Siambo, at the moment, currently, I am not sure what is going on as I'm on leave for some time. So usually we use at PCOE, we get around 1 month. But for the peripheral clinics, it takes more than that. We know, again, it depends on the issue of reagents and the sample. There are a lot of issues around that. But if everything is fine, PCOE we get in a month's time, sometimes even 3 weeks to 4 weeks. Thank you.
Thank you very much. I wish we had lab people around that would guide us and would explain to us what really is going on that.
Dr. Koga, this is Chipasha. For Western Province, yes, I'm happy to announce we've actually been receiving results. But of late, I think from the month of August, the samples that went through in the month of August, we haven't yet received the results. The lab had actually communicated that there was a glitch somewhere. I think they were asked to not process the samples. Don't really have the full details of why they were unable to process the samples, whether it was reagents or, but there was supposed to be some instruction that came through that made them not process those samples, which they have since commenced processing. So maybe that's what led to the hiccup. You could actually follow it up for us so that we get the full information regarding the backlog that's there. Yeah, so because we have backlogs from month of August.
No, thank you so much, Dr. Chipasha, for being very proactive with following up. Dr. Manzi? Okay,
so for Lusaka, I think the biggest challenge that we've had is the viral load samples and the genotype samples. We are going to, or have been going to 2 different labs. So the viral load may go to adult site and the genotype goes to the pediatric section. So you find that they can only do genotyping if they have the actual viral load results and it's high. So without that, the samples were just being kept. And for a long time, I do agree with Rex, we have not been receiving results. And it's something that we've been discussing with the UTH team. We need to harmonize where the samples are going, such that if a client has a sample, has 2 samples collected, one for genotyping, one for virology. They all go to one lab. So we need to improve on our communication with our labs, and we'll definitely go back and engage and see how we can improve. Thank you.
So any other comments? I think we've read most of the comments here. One says, and too many buddy collections leads to missed parallel collection opportunities from Moses. Yes, that's very true. And then Chimunya emphasizes we should also ensure that we identify 2 caregivers to help reduce fatigue on one caregiver. Yes, those are good practices. And then another comment was just emphasizing from Komena the need to have caregivers coming with the bottles to show how they give the drugs. And I think this is very important because sometimes they completely misunderstand the instructions from the dispensing point. Any other comments from the network? We still have a few more minutes before we can wrap up.
Yeah, so maybe just to add on to what Dr. Muhum has talked about, when the caregivers come with the bottles, you need to ask them, how are they giving the medication they should go through? And when you are giving them the bottles, the new bottles, you need to write on the bottles. Please, let's utilize markers and don't write on the lid or on the box. What happens when you write on the box, say 2 tablets, the moment they leave your department, they remove the bottles from the box and throw the box. So your instructions remain at the facility. So let's write on the actual bottle, not on the lid, but on the bottle. You write 2 tablets in the morning or 2 tablets in the evening, depending on the time you've agreed with them. And emphasize that they need to come with the bottles. You count the pills and they explain how they are giving. Yeah.
Thank you so much. Another additional comment from Mkumbi. Pill counts should also be done to estimate the number of missed doses. Thank you very much. Any last remarks from our experts on the call? Dr. Muya, anything to emphasize on?
No comment, Dr. Ziambo. Just to thank Dr. Manzi for the good presentation. I enjoyed listening to all the discussions. Thank you.
Thank you very much. I appreciate it. Okay, so there have been no further comments. I think it's been a great concise session. I hope we have picked 1 or 2 things from here. And please don't forget to register. Please go to the chat box, click on that forms and just enter your details. It helps us keep track of how many we've been on the call. Dr. Manzi, would you like to give your final remarks?
Yeah, so I would like to thank everyone for logging in. I know when we go for mentorship, we have interacted with some people and we've had discussions, but also thank you to you for giving me this opportunity to come and share on some of the best practices. Many thanks to my mentors, I knew Dr. Thomas, Dr. Muya, Dr. Zimba, I think he's on the call. I've seen Dr. Chimika as well on the call. Thank you so much. Dr. Chungu as well. I don't know if he's on the call. Thank you so much.
All right, thank you very much. We'll see you on Monday for another session on men and men's health. Otherwise, have a good day.